Right, hello, people are joining, so thank you everybody for joining, and I can see people are still coming through, but I think in the interest of time, I am going to start now. So good afternoon to everybody, and welcome to our webinar, which is Advancing Cancer Care Through Genomics. My name is Philandra Costello. I'm the lead nurse for Central and South Genomics Medicine Service, and I'm going to be the host today. As I said, thank you for joining us for what really promises to be quite an informative and I hope inspiring session on how genomics is transforming cancer care. So there is a QR code on your screen for a short pre-event survey. If you haven't already completed it, please do take a moment to do so. It only takes a minute. It really helps us shape future sessions. And there will be another post-event survey at the end of the webinar. So if you can, please do stay on for that. So just a few, if my screen moves, a few housekeeping points before we start. The session is being recorded, so you can rewatch it later, but it also will be shared for all who have registered. Also, if you don't want to be recorded, keep your cameras off, but do please keep your microphone muted during the presentations. And we will move through the talks one after the other, and hopefully with time for questions if possible, but if not, we can keep the questions until the end. And if you do have any questions, do also pop them into the chat, and we will keep an eye on those and bring them forward for discussion after each talk. So I am really delighted to have such a fantastic lineup of speakers with us today. So they'll all be sharing the experience of how genomics is improving cancer care across the NHS. So a quick look at our agenda for today. We will begin with a keynote from Professor Ellen Copson, who will talk about where we are now in cancer genomics. Then we'll hear from Dr. Gillian Crawford, who will give an update on mainstreaming genetic testing in Wessex, particularly. Next, we're honoured to have Aidan Atkins, a patient advocate, who will share his personal experience of prostate cancer in his talk titled Sawubona. Then we'll move on to Professor Olaf Ansauge, who is joining us from abroad. So hopefully we will have him connected, who is going to be speaking on the tissue pathways for rapid histomolecular cancer diagnostics in children, teenagers, and young adults, a project that he's taking on. And after that, we have Dr. Kate Glover, who will present the latest developments from the Cancer Genomics Improvement Programme. And then I'll be sharing some education resources and learning opportunities that are available before we close. Ellen, if you're ready, I would like to introduce. So I am very pleased to introduce our first speaker, who is Professor Ellen Copson, who is the consultant medical oncologist and professor of cancer medicine at the University of Southampton. Professor Copson is also the cancer lead for the Central and South Genomic Laboratory Hub. If you are ready, I can carry on. Thank you.
Thank you so much, Phil, for inviting me to speak today. I'm delighted to be joining you all this afternoon. And Phil's already introduced me, so I'll just briefly mention my disclosures, which are on the next slide. And what I'm going to do over the next 20 minutes or so is, on the next slide, please, Phil. Thank you. Is to take you through a whistle-stop tour of a little bit of looking back at where we've come from in terms of genomics for cancer, a look at where we are now in both terms of germline genomics and somatic genomics, and then sort of a quick glance ahead to see where we're going to be going in the future. So next slide, please, Phil. So the idea of personalized cancer care is nothing new at its very most basic. It's about giving the right treatment to the right patient, but we haven't always been brilliant at doing this. I'm from the world of breast cancer, and for very many years we gave all patients anti-estrogen drugs, even though later investigations showed that only those patients who were overexpressing estrogen receptors actually gained benefit from this treatment. The rest of the patients just got side effects from treatments they were never going to benefit from. So the whole aim of precision oncology is about using the most detailed molecular information we can gain in order to identify exactly how a patient's cancer is likely to behave on an individual basis and what management strategies they're most likely to benefit. So very importantly, we can then spare patients from treatment programs they are unlikely to get any benefit from. Next slide, please. Cancer is, of course, at its heart, a genomic disease. Healthy cells will take on the hallmarks of cancer following damage to the cellular DNA that results in alterations in genes that control the key cellular pathways, and lack of control of the genes, particularly involved in cell cycle control, result in uncontrolled proliferation and development of tumors. Next slide, please. And the whole reason that we have managed to move genomic data out of the research laboratory and into the clinic room is because of the absolute massive advances in the technologies that allow us to understand the genomics of cancer cells. In particular, massive advances in sequencing, and particularly the development of next generation sequencing technologies that allows us to look at the DNA sequence in multiple genes and multiple strands of DNA at once, has revolutionized genomic testing. When the first human genome was sequenced using Sanger sequencing, it took over 12 years and £2 billion to achieve. With modern genomic technologies, we can now look at the entire sequence of the human genome in around 48 hours and at a cost of less than £1,000. And that means that we can now even use even this type of data in routine cancer care. Thanks, Phil. It's worth bearing in mind that when genomic tests were first developed for use in clinical cancer care, they were being provided by a range of different places, different laboratories, some private, some within the NHS, often just specialising in one test at a time. And this resulted in both huge inequity of access to testing, very limited knowledge of genomic testing in many places, but also slightly surreal situations where at one point a colorectal cancer biopsy would need to do a quick tour of the M25 and go to 3 different laboratories in order to access all the available testing. Next slide, please. So the development of the NHS National Genomic Medicine Service in 2018 was really built on one key principle: equity of access to genomic testing, so that all patients with England would get the same tests provided in the same way by NHS laboratories. This was built on the experience and the infrastructure developed during the unique UK 100,000 Genome Project, and is based on the idea that all patients within a certain geographical catchment area will have genomic tests led by one of 7 genomic laboratory hubs, doing most of the work themselves or occasionally outsourcing certain tests to other local genomic laboratory. The testing covers both cancer and rare disease and is associated with, of course, the 7 Genomic Medicine Services Alliance and supported by the National Genomic Education Programme. All genomic tests are detailed in the NHS Genomic Test Directories. Next slide, please. And what's key about the genomic test directory is it doesn't just tell you which tests are available to your patients, it also tells the genomic laboratory hubs how they should be doing them. And as testing has evolved over the last 10 years, there's been a significant change from the original single gene tests that were largely done onto multiple gene panels that are achieved using next generation sequencing, and a sort of extreme version of this is next generation sequencing of the whole genome. Next slide, please, Phil. It's really important to remember when you are dealing with cancer that we have access potentially to two different genomes, and we need to be really, really clear when talking to both patients and colleagues which of those genomes we're referring to. A lot of the tests we do these days are looking at the somatic or tumour genome. We do this to gain information about eligibility for targeted therapies, but also other aspects of care as well, and I'll touch upon this again later. But also in a number of situations, we're looking at the germline genome, that is the genetic sequence that the patient has inherited from their parents and will pass on to their offspring. Next slide, please, Phil. All details of the genomic tests that are available are held within the NHS genomic test directories, and tests related to germline testing are included within the genomic test directory for rare inherited diseases, while those related to the tumour, the cancer itself, are held within the National Genomic Test Directory for cancer. Next slide, please, Phil. Our key reason for doing germline genomic testing in cancer patients is to identify patients who have inherited or developed new mutations in cancer susceptibility genes. The really important thing to be aware of with this type of testing is that it has implications for family members, unlike most of the tests we do in our patients. And therefore, any germline testing requires a documented discussion with a trained healthcare professional. And we do recommend that this is documented on the standard NHS record of discussion sheet. The results will generally take 6 to 8 weeks to come through, and the reason for this is demonstrated on the next slide, which shows the sequence of events. So the testing usually starts with a blood or sometimes a saliva sample from the patient, and following genetic counselling and documentation of that, that is sent for DNA, RNA preparation and sequencing. The variant calling is actually done automatically, but because of the massive implications of germline genomic findings, there's a lot of work done to verify and often recheck these results by our clinical scientists. And this is why it can take 6 to 8 weeks to get a results report for germline testing. Next slide, please. This indicates the whole array of cancer susceptibility gene testing now provided by the NHS. And obviously some of these syndromes are extremely rare indeed, but others are more common. Next slide, please, Phil. And in breast cancer, we are now testing an increasing number of patients for breast cancer susceptibility genes, as we recognise that somewhere between 5 and 10% of breast cancer patients do have an underlying pathogenic mutation in one of these genes. We now test 7 different genes on a standard basis, and the eligibility criteria are complex, but they are increasing the whole time, and it's slightly going forward. So we're going to be testing more and more patients for these underlying gene alterations. Next slide, please, Phil. And the reason for doing this is really summarised in this slide here. A key thing patients always ask me is, are my children going to get breast cancer? And so identifying whether or not there is an inherited risk gene within the family and offering information and cascade testing for family members can be extremely important for our breast cancer patients. But we also have to think about this information could inform their breast cancer treatment journey. Being aware of an increased risk of further breast cancers can inform decisions about surgery, and some patients in this situation will choose to have more extensive surgery, for example, contralateral mastectomies. They may also choose to have their ovaries removed because of the increased risk of ovarian cancer associated with alterations in some of these genes. And we know that some breast cancer genetic syndromes, such as associated with TP53 germline mutations or leaf-Ramini, are associated with increased risks of radiotherapy-related malignancies, and therefore that information will inform decisions about radiotherapy. But increasingly also we're using this information to inform our decisions in the chemotherapy clinic about what drugs we give. We know, for example, that BRCA and PALB2 mutation carriers have an increased sensitivity to platinum chemotherapy. And we also now have access to drugs that have been specifically designed for carriers of BRCA germline mutations. Next slide, please, Phil. So the PARP inhibitors are a group of targeted therapies that have been specifically designed to exploit the deficiency in DNA repair that's seen in patients with germline BRCA1 and BRCA2 mutations. We have known for some time that these drugs are beneficial in patients with metastatic breast cancer, but the pivotal Olympia trial data, which was published in 2021, showed also that by giving a 1-year course of olaparib after standard treatment in patients with high-risk HER2-negative breast cancer does improve overall survival. And this treatment is now recommended by NICE, and it's made it increasingly important that we identify patients who are BRCA mutation carriers much earlier in their treatment journey than previously. Next slide, please, Phil. It's not only breast cancer patients who benefit from PARP inhibitors. There are also patients with prostate cancer and ovarian cancer who may be eligible for PARP inhibitors under certain circumstances if they're proven to be BRCA mutation carriers. And in Lynch syndrome, and I know this is going to be talked about more later on, we know that there's increased sensitivity to immunotherapy drugs. So again, testing patients for Lynch syndrome has become an important part of our care in patients with colorectal cancer and endometrial cancer. Next slide, please, Phil. And I know Dr. Crawford is going to be talking a lot more about this later on, but just to highlight how important mainstream of genomic testing has become in certain oncology clinics in order to access testing for BRCA mutations and for Lynch syndrome early in the patient's journey and to get the results back in a timely fashion so that it can help us with these treatment decisions. Next slide, please. Another way in which we're using germline genomic information is to reduce chemotherapy toxicities. We've known for some time that patients who inherit an alteration in the DPYD gene are not as efficient at processing certain chemotherapy drugs, such as 5-FU and capecitabine. This results to buildup of these drugs in the circulation and potentially dangerous levels of side effects. It is now mandatory that any patients we recommend these sorts of chemotherapy drugs undergo testing of this specific gene so that we can identify whether they are going to have a problem processing this drug, which means we should either avoid it or reduce our dose that we give the patients. Next slide, please. I'm now going to move on to talk about somatic or tumour testing. And as you can see here, the pathway for genomic testing of tumour samples is very similar to the one I showed you earlier. But here we do need the time and support of our pathology colleagues to identify the best area of a tumour biopsy or sample to be sent for genomic testing and to provide key information about the cellularity of the sample. And to support this pathway, a new network of regional genomic pathology centres is currently in development. Next slide, please, Phil. The understanding that different tumours carry alterations in different genes to drive them has become a key part of drug development over the last 2 decades. Now, a clear pathway for drug development is for the laboratories to start by identifying which genes are commonly altered in particular tumour types, model the impact of the gene alterations on the cancer cells, and then design drugs which specifically target the altered pathway. Next slide, please, Phil. One of the earliest and most instrumental drugs to follow this pathway of development was vemurafenib in metastatic melanoma. It had been observed that about 50% of patients with metastatic melanoma had a single alteration, V600E, in the BRAF gene of their melanoma cells. Vemurafenib is a BRAF inhibitor specifically designed to exploit this altered pathway. And as you can see from this key phase 3 trial here, when compared to dacarbazine as a treatment in patients with metastatic melanoma, it had significant benefits. And you can see on the right of this slide the clinical impact this treatment had on one patient after just 9 weeks of administration, almost complete resolution of their extensive subcutaneous melanoma deposits. Next slide, please, Phil. And one of the reasons targeted treatments have been so favoured by oncologists over the last few decades, as well as often being more efficient and effective than conventional chemotherapy drugs, they're generally much more tolerable for patients with much less in the way of the widespread toxicities that we see with conventional chemotherapy agents. Although that's not to say targeted therapies do not have side effects, and they still have to be monitored and closely supervised in the oncology clinic. Next slide, please, Phil. Over the last 15 years, we have seen multiple new targeted agents developed that have really transformed the care of many tumour types. For non-small cell lung cancer now, there are heaps of guidelines devoted to the management of what's become known as oncogene-addicted metastatic non-small cell lung cancer. These are non-small cell lung cancer tumours where specific drivers can be identified by genomic testing at diagnosis that will identify what the most appropriate targeted drug to use as first-line therapy is for these patients. Next slide, please, Phil. Even breast cancer, which for a very long time has continued to only use estrogen receptor and HER2 receptor status to identify a treatment pathways, has now gained access to 3 targeted drugs over recent years, which all require genomic testing to look for alterations in PIK3CA, AKT, P10 and ESR1 mutations. And all of these drugs are now NICE approved for use in advanced estrogen receptor positive breast cancer, providing we can demonstrate the presence of one of these drivers. Thank you, Phil. Next slide. And this slide, I'm sure, is out of date again now because I have to update it so frequently. But this is just a demonstration of the number of different agents we are using that require genomic biomarkers for us to access it in different tumour types. Next slide, please, Phil. But we are also becoming increasingly aware of the idea of tumour agnostic genomic testing, the idea that if a certain biomarker is present, that we can use a targeted drug regardless of the primary tumour site. And this is the case with the NTRK inhibitors, a group of drugs that have been specifically designed to target patients with tumours who have an NTRK fusion gene. And this is a prominent tumour driver in a number of adult and paediatric tumours, although they do tend to be the rarer tumours rather than the more common ones. Next slide, please, Phil. Other features we can look at from a genomic point of view that can help inform treatment choices include mutational signatures. This is the pattern of genomic alterations that can give us clues to the etiological basis of a tumour. And where the pattern indicates a homologous recombination deficiency, such as seen in patients with germline BRCA1 alterations, but also seen in the absence of these, this can indicate sensitivity to PARP inhibitors and is accepted as an eligibility for PARP inhibitors in certain cases of ovarian cancer and is being increasingly used in clinical trials of this type of drug. Next slide, please, Phil. We can also use mutational load as a biomarker for treatment. We know that patients who have tumours with high mutational burden are increasingly sensitive to immunotherapy drugs. And indeed, in the colorectal cancer setting, demonstration of high mutational load can be used as a biomarker for access to immunotherapy. And again, this is increasingly being used in clinical trials. Next slide, please, Phil. And this has really led to a paradigm shift in the way clinical trials are being designed in oncology. For most targeted therapies, no longer limited now to single tumor types. Instead, patients for multiple tumor types can enter and will then be allocated treatment based on the particular genomic markers found within their tumor types. Next slide, please, Phil. Other ways we're using genomic data are also to inform chemotherapy decisions. For example, in breast cancer, where RNA expression profiling of various genes known to be associated with proliferation and metastases can provide us with individualized risks of patients' cancer recurrence and therefore help us to inform adjuvant chemotherapy decisions. We're also using genomic information to inform difficult diagnostic decisions, and also there is a lot of research being done to use genomic markers as a way of monitoring response to treatment as well. Next slide, please, Phil. But there are challenges of using genomic data, and you need to be really clear that just because you have a genomic biomarker, that does not provide guarantee that a tumour will respond to the targeted therapy. Overall, response rates in these types of trials tend to be around 50%. And in addition, we know that these treatments don't often last forever. Most patients will sadly develop resistance, such as the patient I showed you earlier from the vemurafenib trial. Next slide, please, Phil. And this is because we know that as patients develop more progressive disease, we will see changes in the genomic profile of the cancer. And as they develop more and more metastases, we will find different genomic profiles in the different metastatic deposits. Next slide, please, Phil. And this causes issues when we're looking at the genomic profile of a single metastatic biopsy. We also know that tissue doesn't always give us enough DNA for successful testing, and also that, for example, if you're doing whole genome sequencing, that you need a high quantity of DNA, and that formalin fixing does affect this, and that's why we need fresh tissue for whole genome sequencing. Next slide, please, Phil. And this is why ctDNA is becoming such an attractive proposition for the future. This involves amplifying the tiny amounts of DNA found in the peripheral blood to give us information about the tumor DNA sequencing. It's obviously better for the patients. It requires a blood sample rather than a tissue sample, and it also allows longitudinal testing, which can be very important in tracking mutational changes. It also potentially gives a much better overview of the whole genomic landscape rather than individual metastatic deposits. Next slide, please, Phil. And following a very successful transformational program that our GMSA was so active in, this is now available routinely for patients with non-small cell lung cancer, but also for patients with advanced breast cancer as well. And this is likely to become available in carcinoma of unknown primary in the next year or so. Next slide, please, Phil. Going forward, the NHS Genomics unit has got very big aspirations for genomics and hopes it will be using it in all aspects of cancer care going forward, with the particular emphasis of ctDNA to help us identify treatments, but also in monitoring. And we're looking to move genomics more and more into prevention as well and early detection. Next slide, please, Phil. Clinical trials are also high on the agenda, and there is a framework in place to add in extra genomic information that is not required for standard of care treatment at the moment, but might help us match patients to clinical trials going forward. Next slide, please, Phil. But of course, we all know that the NHS is financially challenged at the moment. And what we've seen this year is a real new emphasis on us taking responsibility to make sure that we're requesting genomic tests appropriately and to make the most of our financial resources. Next slide, please, Phil. And this has particularly affected whole genome sequencing, which is now longer available for all patients, but it is now being really focused towards those patients where it's most likely to have clinical impact, namely young patients and those with CNS tumours, as well as patients who have exhausted routine testing. Next slide, please, Phil. So I'm going to finish there, hopefully just on time. Hopefully what I've got across to you is that we are increasingly using both germline and somatic genomic information to inform our patient care in the clinic. I think circulating tumour DNA is going to become more and more a practical way of achieving this. But the cost effectiveness of genomic testing is going to come under increased scrutiny. And ultimately, I hope what I've got across to you is that precision oncology is all about the right test for the right patient at the right time so they can access the best possible treatment. Thank you very much for listening.
Thank you so much, Professor Copson. That was such an excellent overview of where we are now. So much progress so quickly happening. I can't see any questions or in the chat. So I just have one very quick question, and I know you have to rush off, is what do you think is the biggest challenge that we have now in the NHS healthcare professionals in keeping on top of all of these changes?
I think the speed of progress is huge. It feels that every a time I look at the test directory eligibility criteria for BRCA testing of change, new drugs coming, new tests. So I think, just keeping up to date is a challenge. I think for people who perhaps haven't used genomics much so far, there's, education, getting used to the genomic language, being really clear about the difference of germline and somatic when talking to patients is so important. And so I think, we all have a challenge to really spread the word and educate our colleagues through events such as today. And then, of course, the really big challenges. I've just come from ESMO Cancer Conference, vast numbers of new drugs coming through, really exciting, results. And of course, the massive elephant in the room is how the NHS is going to be afford all these novel therapies that are coming in, and how we can make sure our patients continue to get access to the best possible care is going to be a bigger question than I think I can answer here today. But if anyone's got the solution to that one, please do let me know.
Thank you very much for your talk. Really do appreciate it. And I know you have to rush off. So unless anybody had anything, question, put it in the chat and we might come back to you, Professor Copson, with that question by email. Thank you.
Thank you so much for having me. Bye-bye.
Bye-bye. So after all of that information now, really going on to our next talk, if I can move, we really pleased to introduce Dr. Gillian Crawford, who is the consultant genetic counselor at Wessex Clinical Genetics Service. And Dr. Crawford is going to share an update on mainstreaming cancer genetics within Wessex. So thank you so much for joining. Gail, are you happy for me to move your slides, or?
I am, apart from I think I've been a bit annoying and I've got a couple of bits coming in, so I might have to say it quite a lot, so sorry about that.
Don't worry.
Next slide,
don't worry.
please. Yeah, move on, please. So what I'm going to talk today really, I suppose, is thinking about translating a lot of the things Ellen's talked about into how do we support our cancer care colleagues to be able to take forward a lot of this genomic testing in their routine day-to-day oncology clinics and work that they're doing. And the Wessex Cancer Genetic Testing Programme was set up back in 2020 now, initially with funding from within the Trust and the Wessex Cancer Alliance, to look around mainstream testing, particularly of the BRCA and PALB2 genes at that time in patients with breast and ovarian cancer. The scope of the mainstream programme developed pretty quickly, and there was sort of much more work to be done. So the Alliance funded the clinical posts for a further 2 years up to 2025, and they've just secured funding beyond that. So we're very grateful to them for supporting this work. Next, please, Phil. All of this work fits very much with their strategy, their cancer strategy, but also their cancer genomics strategy over the next few years. And we can see genomics featuring very highly within the new NHS 10-year plan. So genomics isn't going anywhere. It's just going to become more and more of our sort of routine care going forward. Next slide, please. So the Wessex mainstreaming programme was set up to be a transition project to looking to deliver safe, equitable and timely provision of genetic testing to patients who are having cancer treatment. So this is not for family members who are unaffected by cancer wanting to talk about their risk. This is for people in cancer treatment where these results may well make a difference, as already illustrated earlier. Next slide, please. Mainstream testing really is a legacy of the 100,000 Genomes project. Many people on this call may have been involved in that project, which was looking to transition genomic testing out of specialist services like clinical genetics into routine NHS care. And that was very much within oncology, but also across the board in paediatric services, neurology, cardiology, etc. This document from 2020 talked about clinicians being empowered and supported to be able to identify which of their patients would be eligible for genetic testing, to know what test they should offer those patients, to know how to interpret the results and what to do next in terms of managing that patient and referring them on. And we very much saw the mainstream programme to be key in doing those two elements of empowering clinicians to say, yes, these are tests you can organise directly, but also supporting them as they learn how to do that, but also learn what to do with the results when they come back. Next slide, please. So identifying these patients who have got a high risk of developing cancer, so have a germline variant, is really important in terms of improving cancer diagnosis. So very much thinking about earlier diagnosis, but also for patients with symptoms, that those symptoms are investigated promptly. Once we have a patient diagnosed with cancer, we want to optimize the management of that cancer, but also their follow-up program, because for many of these patients, they will have a significant risk of a second primary cancer. So we need to make sure that that is accounted for in their follow-up plans. We've already talked a lot this morning or this afternoon now about tailoring of therapies, and this is a key reason for offering these cancer patients testing at the point of diagnosis or during their treatment pathway. If we identify someone with a germline variant, then that may well have implications for their relatives who may be at risk of having inherited that variant as well. So we very much want then those patients to be able to access predictive genetic testing so they too can have earlier screening for earlier cancer detection, and if they want to undertake risk-reducing measures like risk-reducing surgery. Overall, that will be effective for the NHS if we can prevent cancers and treat cancers more effectively. So sort of that is a strong driver, I think, for supporting this work. Next slide, please. So at the time when the programme came into place, we had these national initiatives that were also being embedded. You've seen an example this afternoon of the National Genomic Test Directory, and one of the key things in that, as well as putting forward the eligibility criteria for testing and what tests would be done, what genes would be looked at, is which clinicians could order testing. So we were seeing then the tests where oncology or surgical colleagues could organise testing, and those tests that were just to be the remit of specialist services like clinical genetics. So that was really opening up the test much more widely to cancer care colleagues. We've seen a reconfiguration of the genomic hubs and the genome medicine services, really to try to deliver an equitable service across the country, because we were seeing some inequity prior to this. Move on, please, Phil. There was a whole sort of education program to go alongside this to help colleagues. Many of those resources can be found on the Genomics Education program. I've put the link there, where they range from very bite-sized, few minutes, little webinars, to much more comprehensive resources and education materials. There's webinars like the GMSA webinar we're all at today, but there's also much more developed education opportunities. For example, there's various MSc in genomic medicine courses across the country, and locally in Southampton we run that course with a module in genomic counselling that I co-lead with a colleague. And health professionals are encouraged to do these courses, and they can do our counselling module as standalone, or they can do as postgrad certificates, diplomas, or right up to master's level. So there's a lot of flexibility within that. We have organised primer days here in Southampton, which are one-day study days to get healthcare professionals up to speed with more of the basics around genetics that people maybe don't remember from their undergraduate training, and also some oversight on interpretation of variants. We offer localized training for the mainstream program because that's much more around what needs to happen locally, how can you organize these tests, what documents do you need, and what resources are available. And we have an in-clinic resource called Genotes where clinicians can look things up during their clinic to guide them in what tests might be available for those patients that they're seeing. So there's been a lot of support on a national basis, and we were looking to deliver that locally as well. Next slide, please. Yeah, move on. So in terms of the mainstream program, we identified that there was various areas within that we needed to look at. Initially was some scoping and gap analysis work. What's already happening? What needs to be put in place for this to be taken on by our cancer care colleagues? What resources can we develop to support them? Everyone's really pushed for time in their clinical work, and what resources would patients benefit from, but also clinicians would benefit from some of the more generic information being delivered in other ways, with the clinical discussion then being much more related to that particular patient. We needed to be able to embed this testing in pathways, so this shouldn't be a sort of separate standalone thing that's an extra burden, an extra thing. We need to see how it can be done as part of the patient pathway already in place. We set up the mainstream education program with some ongoing support in terms of clinic observations, for example, and so far 170 clinicians have attended that program across Wessex. While delivering these resources and training programs, I set up a mainstream virtual clinic, which was designed for patients who would be eligible for mainstream testing who had cancer, where they could be tested on a video clinic, which meant they could be seen more quickly than in the general genetics clinics, which often had a long waiting list, so that results were available for treatment decision making. But also for many of these patients, they were in chemotherapy treatment, so were very happy not to attend a face-to-face appointment and put themselves at risk of picking up infections, for example. In addition, it also meant that I could get some idea of the numbers per centres of patients coming through that would be able to have a mainstream test, and therefore in terms of planning for workforce and capacity, it meant that those individual centres could say, okay, well, I think this will be about this amount of time that we'll need for someone to take this forward. Next slide, please. So as I said, the program was initially set up to look at ovarian and breast cancer patients, but very quickly Lynch syndrome became a national transformation project, and so there was a lot of focus on the development of mainstream testing in Lynch, with some nice guidance around the use of PARP inhibitors. Prostate cancer has become more of a priority area, and that's one of the key areas that we are delivering education in currently. And looking forward, we are hoping to progress our work in the area of pancreatic and endocrine cancers, and in dermatology, particularly melanoma. Move on, please, Phil. So in the ovarian side, many patients are offered parallel somatic and germline testing to guide treatments, and that is now fully mainstreamed across Wessex, and that has been gynae clinical nurse specialist led. So the gynae-oncology nurses are leading on consenting patients, organising the test and disseminating the result. Move on, please. In breast, we are offering germline testing for those who meet the eligibility criteria. That's sometimes at the point of diagnosis and sometimes later on in their oncology treatment, as they may be eligible for PARP inhibitors. That is now fully mainstreamed across Wessex, apart from in one centre, and that has been multi-professional, where we have had clinical nurse specialists, but also oncologists and surgeons consenting patients for testing. Move on, please. For Lynch, because this was a national project, there was some funding for us to be able to appoint a Lynch syndrome genomic nurse or genomic counsellor. My colleague Catherine is in that role, and I've got some of her slides later. And that was to ensure that we were able to deliver the nice guidance around tumour testing for colorectal and endometrial cancer patients, and then in time to start organising germline testing for Lynch in the mainstream setting. She's done great work in moving that forward, as well as the Alliance supporting some embedded Lynch syndrome clinical nurse specialist posts in the MDTs across the region, and that has been fully CNS led. In prostate cancer patients may be offered germline testing at diagnosis, but for many patients with secondary disease, they are offered somatic testing and, if indicated, germline testing to guide PARP inhibitors. We started training for that last year, and that work is progressing well, and again has been multi-professional. We've had oncologists, urologists, and CNSs take that forward across the region. It's not fully mainstreamed yet. And as I said, for pancreatic and melanoma, we are looking to work with colleagues on that and taking it forward. We know many patients with pancreatic cancer present late, so we are ensuring initially that DNA is stored, so that's available, and then we are looking to develop training so that the teams can take on the testing at diagnosis. We've got a large cohort of retrospective and current melanoma patients who will be eligible for testing, and we're looking to work with dermatologists in that area. Next slide, please. So I just thought I'd give you a flavour on how the work's progressing. In 2021, across breast, ovarian and prostate cancer, we were seeing 180 tests organised by mainstream clinicians back sort of in 2021. That would be primarily ovarian cancer patients, because that's where the mainstreaming started. And you'll see that up to September in this year, so the first 9 months of this year, we were already at 655 mainstream testing. So year on year, that is increasing significantly, which is good news. Next slide, please. For Lynch syndrome, we know that that is very under ascertained at the moment. They estimate that we only know about between 5 and 10% of Lynch syndrome patients nationally. So there was very much a drive to be able to identify these patients, which is where a lot of the tumour testing came in. Next slide, please. With the NICE guidelines for colorectal endometrial cancer. This is the colorectal cancer guidelines. You can see it's quite complex and busy, where patients are given some initial tumour testing, and depending on the results, will go on and have additional testing. And you can see why this would be complex to deliver in the MDTs if this wasn't coordinated sort of more centrally. And that's why we wanted to embed clinical nurse specialists in the colorectal and endometrial and gynae MDTs to make sure this pathway was being followed. Next slide, please. We audited this work at the beginning to see how that was actually being delivered, and you can see the green is when people are meeting the targets, and then the darker orange is where we're missing that, and you can see that it tails off. The initial tumour test is done really well, and then as the subsequent tests are indicated, that tails off right through to not all patients who need to be being referred to genetics at that time. Next slide, please. We saw similar results in endometrial cancer. Next slide, please. So we identified areas that we wanted to focus on, which was identifying a Lynch champion in each MDT across the region, which we achieved, Catherine achieved pretty early on. Then we looked to embed clinical nurse specialists in those MDTs to deliver on that pathway, again, which was very well supported with the Alliance funding. We were achieving over 90% of patients being offered immunohistochemistry, that initial test on their tumour. That was happening really well across the region. And we are now in a position where there's CNS is taking forward germline testing in mainstream clinics, and you'll see that those areas in red are where there is either yet not provision for that, or where they are just starting. So the yeses are where they're just starting. So great progress has been made in Lynch syndrome. Next slide, please. We've seen that deliver in terms of speed of testing. So we have done now 45 mainstream germline tests in Lynch syndrome. Quite surprisingly, only about a quarter of those have actually got a confirmed Lynch syndrome diagnosis. Many have tested negative on a germline test, so there is a lot of challenge on how we manage those patients who have tumour tests indicative of Lynch, but we haven't confirmed that in a germline test. How do we manage their family members in terms of bowel screening? And that work's ongoing. But you'll see that there has been a significant reduction in timeline. So we were seeing well over a year for the pathways from that initial tumour testing to the final germline result being fed back to patients when they were coming via clinical genetics. When it's all been done in the mainstream setting, from the germline discussion to having that result is 67 days. So it's much more timely for patients to have that information and to be able to talk to their families. Next slide, please. In terms of developing resources, we developed some online resources. Breast Cancer Choices was an existing decision aid for patients that we've used in the mainstream setting, where breast cancer patients were given the opportunity to look at this prior to consent. Next slide, please. This is the front page. Move on. This is where patients can click on boxes to get much more detailed information. Move on. Then they can have a presentation of what their different options might be. Move on. And then they can fill in a questionnaire to think through their decision making. Next slide, please. We've evaluated this and we've seen significant drops in decisional conflict for patients who, from the time before they used it to the time after they'd looked at the resource. Next slide, please. And patients have found this very acceptable in terms of satisfaction, how easy it was to use and whether they'd recommend it. Move on, please. And we evaluated this with over 100 patients who logged into it on average once, but some a few more times, and spent on average 23 minutes on the resource to go through that and to help with their decision making about genetic testing. Next slide, please. We've secured some funding from Breast Cancer Now. Move on to look at optimizing it, so making it more inclusive for male patients, transgender patients. We're going to use animations for patients who don't want to read lots of text and translate sections of it. And we want to be able to use it in the predictive testing situation as well. Move on. And then we want to try and make sure that's implemented as an available resource nationally, so it can be embedded into care pathways. But we need to remember our patients who don't want digital resources and make sure they have equitable resources as well. We're looking to develop it in other disease sites, ovarian, prostate, pancreatic cancer, and it could be used alongside Lynch Choices, which is a great resource for our Lynch carriers that can be part of a suite of resources there. Next slide, please. And so just to finish, I just wanted to mention a couple of areas where the mainstream program is inputting. Ellen's talked about circulating tumour DNA, and we are increasingly finding germline variants in that test, perhaps completely seemingly unrelated to the cancer diagnosis that patient's been tested for, and we need to help our colleagues in cancer care to know what to do with those results. We now have some guidelines published for that, and we are also having to manage incidental findings where patients are having genetic testing for another reason, so perhaps a childhood developmental delay, having a whole genome sequence, and we are finding that patients have a germline predisposition to cancer. So we need to help colleagues not used to looking after patients with inherited cancer predisposition to know how to manage those results. Next slide, please. And with all of this, because we are looking at germline variants, it has many counselling and ethical issues as part of that discussion and ongoing work. We have patients seeking direct-to-consumer testing and then having results that they can't work out what they mean, can't interpret, and we need to support colleagues as they help patients navigate that. And there is now some published guidelines for that. Move on, please, Phil. And then we often get requests to test children where we wouldn't necessarily do that for adult onset conditions. So we have guidance to help managing that. And we are certainly locally in UHS, and I know Birmingham has for a while been taking part in the Generation study looking at newborn screening. There's very little cancer testing as part of that project currently, but that may develop in the future, and we need to think about that carefully in terms of having this information in newborns and how that is managed from an ethical perspective long term. When we identify a patient with a germline variant, we encourage them to share that information in their family. Families are not always straightforward. There's lots of complexity. There may be family breakdown, and those patients will come to clinical genetics for us to help them share that information. But our cancer clinicians will often start those discussions when they're consenting patients, when that comes to light, that there may be difficulties. That makes us have to question the whole concept of consent to testing, but also confidentiality and breaching confidentiality if patients are not willing to share with relatives. And we spend a lot of time talking to colleagues and when we train about managing that if it comes up in clinics. Patients have questions around insurance and how that might impact insurance going forward. So these are lots of the issues where we need to support our colleagues as although genetics will often take these discussions forward in a more detailed way, it does come up in routine oncology care. Move on, please, Phil. And we have guidance around consent and confidentiality. So I'll stop there. I think I've got to the end of my time. It was really just to give you a flavour of some of the work that we're doing in the hope that if we can support colleagues and get this embedded in routine care, it won't be reliant on an interested clinician in one area doing this who then maybe leaves or moves on and therefore all falls apart. We want to see this embedded in routine NHS care. Thank you.
Thank you very much, Gil, for that really clear update. I think it's really great to see how genomics has been embedded into everyday practice. I don't know if anybody has any questions. Please do put your hands up or pop it in the chat. But just a quick question from me is that what is the biggest, again, just going back to the same kind of question I've asked the previous speaker, but what has been your biggest challenge mainstreaming genomics across different trusts?
Yeah, I think really it comes down to capacity. Clinicians very much feel like they are overstretched as it is, and this is another thing that they have to. Are you expecting me to take this on? There's also been a little bit where they've thought, well, you've got clinical genetics, you've been doing it, why can't you just carry on? But what we've seen is, of course, as soon as it starts impacting treatment decisions, they're much more engaged with it because they see actually we would really benefit from knowing this as soon as we can and having that information. So I think it is about capacity. And I think the problem is sometimes things like there's nice guidance for a drug and suddenly it comes in and nobody said, well, okay, well, now you've got all these patients eligible. How are you going to cope with prescribing that, assessing them for side effects? They might be on the olaparib they take for a year. They've got to be monitored for that whole time. It's all additional work. So it's very understandable about that concern. So I think really it's about having that element of support and resources and saying, well, actually, you're doing a lot of tumor testing now. This is not that different, but you just need to make sure you cover with the patient the implication of a germline finding for them and their family members. And so it will be an extra bit of discussion, but actually let's see if we can just get it as part and parcel of those discussions you're already having. Some centres have done separate clinics and that's worked really well because they've had different people doing that on a rotational basis, so it shared the load. And so I think that can also be really helpful to feel that it's a team approach rather than just an individual clinician.
Well, thank you very much. I'm just looking on the chat and there's nothing there, but thank you very much because I know you've stepped in for Catherine to do this presentation for us. So thank you.
Okay, thank you.
Right, so moving on then, our next speaker, I'm really pleased to introduce. This is Aidan Atkins, who is a patient advocate who's going to share his personal experience of prostate cancer in what I think is a fantastically titled talk, Sawubona. So we're really grateful to Aidan for joining us today to share his story and perspective. So Aidan, I'm going to move your slides for you, so just let me know when you want to go forward.
Yeah, please, next slide. So as Phil said, Sawubona, it is, hopefully some of you have come across this. It's a Zulu greeting, and it basically means, I see you. And as it says there, it really means, I see you deeply. You know, it's not just, you know, good morning, but really, really sees you deeply. And it's interesting, you know, that it's not just you're seeing the person, but when we're talking about genomics, we are seeing, you know, the complete, you know, DNA as well. And, you know, certainly personally speaking, I want to be seen. I want to be seen as not the 1130. I want to be seen as, you know, Aidan Adkins, the, you know, the person with a family, you know, what my background is, what my understanding is. So, you know, so this is an appeal to, on behalf of all patients, you know, please see us. And I came across this term. I'm a patient advocate on the West Midlands Cancer Alliance, and we were circulated a brilliant YouTube video made by Professor Alex Brunelli, a thoracic surgeon from Leeds, but he also happens to be the president of the European Society of Thoracic Surgeons. And his presidential address introduced to all the other thoracic surgeons this concept of Sawubona, you know, please see your patients, really understand them. And surprisingly, you will get better results. So what better way to introduce a genomics presentation? So what I'll cover, and next slide, please, in no particular order, but you know, these are the things that happen. You know, as a patient, you want to know, well, why me? Why has it happened to me? And then, as we've heard, you know, every journey is different. You know, the different challenges, and you really need the patients to be engaged. And, you know, we've heard that already. And absolutely personalized treatments, because we are all different. And then trying to wrap it up with, you know, what are the next steps. So next slide, please. So here's a bit of name dropping. That's me on the left, and I have to keep saying it's to the left of James Cleverly there. I was diagnosed 10 years ago now, November 2015. It was a routine work medical, no symptoms, age 53, no family history. white ethnicity, fit, nothing else wrong with me, and didn't know the cause, wasn't able to be told the cause. And this is me at the Houses of Parliament a year ago, doing a speech supporting the launch of a report that is trying to get targeted screening on the agenda. So James Cleverly, 1 in 4. So myself, 1 in 8 risk of getting prostate cancer now that I hit 50. James Cleverly, 1 in 4, a black man. David Lammy, 2 brothers with prostate cancer. So not only is he 1 in 4 because he is a black man, but because he has 2 brothers, that really ramps up his personal risk. Josh Barbadine, a Lib Dem MP, a black guy, 1 in 4. Then Oliver Kemp, he's the CEO of Prostate Cancer Research. He is 1 in 8, like myself. And then Sir Steve McQueen, the Oscar-winning film director, his father died from prostate cancer, so he was at least a 1 in 4, and that risk increasing with his family connection of 2 to 3 times. And he was proactive in his quest to discover whether he had prostate cancer, and so being a wealthy individual, he was regularly getting tested and having MRI scans, and ultimately was diagnosed with prostate cancer and had that dealt with. And so all of your work hopefully will go away if we have good screening, catching cancer early as well. But as we know, some men are more at risk than others. So next slide, please. Things are only getting worse in terms of the number of people being diagnosed because we're all living longer. And this is a recent study that was commissioned by the Lancet that shows it's going worldwide from 1.4 million cases in 2020 to 2.9 by 2040. And we don't know what causes it. So we don't know how to prevent it. We need to be ready for it. So next slide, please. One of the things I also do is awareness talks for Prostate Cancer UK, and these are the typical slides we present. And it's a reminder, 1 in 8 men across the UK will get prostate cancer. So more than 63,000 men are being diagnosed every year, and 12,000 men are dying every year. But we do have over 500,000 living with or after prostate cancer. We do know that some men are more at risk than others. That first risk factor is age. And there it is from the age of 50 or over. But some men are particularly at high risk. We've touched on black men. 1 in 4 black men will get prostate cancer. Then men with a family history of prostate cancer, breast cancer, or ovarian cancer are also at higher risk. So first phone call I made when I was diagnosed was to my brother, and he regularly now gets a PSA blood test from his GP. And then men with the BRCA genetic mutation, and apparently, just looking at the numbers this morning, in the inherited, or rather people with a hereditary prostate cancer, that's 5 to 9% of all prostate cancers, but 12% of metastatic are hereditary cancers. So that's the level of risk coming through the genes. Next slide, please. So there was a time when men were very, very quiet about it. They were diagnosed but didn't tell anyone. Bob Monkhouse was famous. He didn't tell anyone until after he died. So there's a big set of celebrities there who have been quite vocal. It seems that you've got to have a knighthood, and when you get a knighthood, they say you need to tell people if you've got prostate cancer, because there's a lot of knights of the realm there with diagnosed with prostate cancer. And not everybody is prepared to go public, and that's obviously a personal decision. It took Sir Chris Hoy a year to tell people he had cancer, and then that it was actually prostate cancer. And King Charles is obviously very private about what particular cancer he has. So absolutely, some people want to be confidential. As we've heard, this could be for insurance reasons, family reasons, or even they're still looking for work. And yes, some employers don't necessarily hire people when they know that they've got cancer, or even relatives have got cancer. There was a shocking case recently, I don't know if you saw in the news, a young woman was trying to join the army, and the army rejected her. And they said the reason for rejection was because your mother had breast cancer. She appealed that. I don't know what happened to the person doing the medical, but they quickly restated their case, and she did in fact join the army. But that is kind of like an indication. If the army are up to that, then you can imagine the small employers are also up to no good, despite it being a protected characteristic. So, not everybody is as educated as these individuals as well, or have access to, the top oncologists and clinicians in the country. But it is so important for patients to be engaged and involved in their, their diagnosis. And this next slide, indicates why. So this study is a massive study back in 2020 of men who've been diagnosed with prostate cancer. So nearly 17,000 men, and that split quite quickly. Those who were definitely involved in their decision on treatment and those who weren't. And the shocking thing is, if you are engaged, and things go a little bit wrong, you get these bowel, urinary, sexual dysfunctions, then the level of regret, is quite low, 17%. For those same, issues, urinary, bowel, sexual function, the level of regret, if you haven't been engaged, is a massive 51%. So low involvement, high regret, high involvement, low regret. So the importance of, getting men engaged in their treatment decision making is so important, but it is a challenge. So next slide, please. And I think Gillian Crawford pointed this out with some of the interventions that they're doing there. 16% of adults in England are functionally illiterate. You give them a leaflet, they cannot read it. And then Public Health England said, they did a study and they said 61% of working age people don't understand the simple health and well-being information that they are given. So that's health illiteracy, if you like. And then, as mentioned, also, back in 2020, hopefully this is improving, 6% of adults had never been on the internet. So, what is a QR code? It's a pretty pattern. So you need to recognize that, people do face these literary challenges. And I see it all the time. I run 2 support groups, the Solihull support group and an online support group for advanced prostate cancer. And we do come across people that have got these literacy challenges as well. So next slide, please. So this is from a paper which has Professor Copson probably recognizes, very quickly gets out of date. This is the contemporary management of prostate cancer. So things are so fast moving. I was fortunate enough to be a patient rep on this paper, which is globally published. And this diagram shows, this is what happens to prostate cancer. The cancer growth. This is for the 12,000 men that are dying every year. This is what happens. There are a number of treatments, but some treatments work better for others. So I know one man who's been successfully on hormone treatment. So his hormone sensitive prostate cancer has been hormone sensitive for 20 years and counting. I know one man who's been on the new drug abiraterone since the very first clinical trials. For 14 years it has been successful, and yet the average success for this androgen receptor pathway inhibitor is 8 months. So, averages, what does that mean? We are all fundamentally different. So my particular diagnosis, next slide, please, is a very similar picture. So this is my PSA progression, which is a good biomarker for tumor growth. Nearly 10 years ago now, I had my prostate removed. That didn't work out. I had salvage radiotherapy, 33 sessions. That didn't work out. I had 2 years on adjunctive androgen deprivation therapy or chemical castration. And then when I came off that, it was attempted to kill the 1 tumor or 2 tumors that were visible on a scan using targeted radiotherapy, SABR. That worked out, but the next scan showed another 8 tumors. So onto the systemic treatment, chemotherapy, and then onto the androgen receptor signal inhibitors, which are now known as androgen receptor pathway inhibitors, because nobody liked the word RC for some reason. And then onto another set of chemotherapy, 10 sessions this time. And then more recently, I had spinal cord compression and 5 sessions of palliative radiotherapy. So yeah, this is, following what is happening. So the importance of, really understanding and engaging, with what is going on. Next slide, please. And along the route, just after my first set of chemotherapy, and you can see my hair disappearing in these shots there, I did have that genetic testing. And this was the simple sentence on my letter to my GP: no pathological variant detected for BRCA1 and 2, and therefore not eligible for the PARP inhibitor olaparib in the future. And I must say, this was despite the fact that that PARP inhibitor would have had some success increasing my overall survival, it wouldn't have saved my life. And so, quite frankly, I was quite relieved that I didn't have the BRCA1 or 2 mutation, genetic mutation, because I've got a 28-year-old daughter, and those conversations weren't required there. Having said all of that, next slide, please. Olaparib, do you know what? It's working for other genetic mutations. And I do know some men that have never had the genetic testing, but their oncologist has put them directly onto olaparib because, do you know what? It might be working for some other genetic mutations as well. And so, this is, a little bit of a campaign at the moment to really try and push, can more men be on olaparib? So going forward for me, I'm about to start a clinical trial in November. Next slide, please. And I am encouraging all men to join something called Prostate Progress. And this is organised by Prostate Cancer Research, and in conjunction with NHS data. It's about us patients, putting all our data into a central repository that is secure, that is well looked after, and not everybody gets access to it, but yes, absolutely, pharmaceutical companies can get access to it, because the thing that that really surprised me when I was first diagnosed is that there wasn't much inquiry as to, well, what kind of prostate cancer is it? And as we saw, yes, genetic testing for olaparib has only been a relatively recent thing. And so the question is, at what point does that actually start happening? But please do encourage anyone to, provide their genetic information for future research, and who knows, that also may give them access to a genetic trial. So that's the end of my presentation. Hopefully it's given you a little bit of an insight, and it's absolutely supported the previous 2 speakers, the importance of getting your patients engaged, the importance of confidentiality as well. Some patients don't want their photo in the paper. They're not even telling their nearest and dearest. And that is a personal decision that needs to be respected. And some patients have no idea. I mean, I'm an engineer. When I started on this journey, I had no idea what the difference was between a radiographer, a radiologist, an oncologist. This was alien language to me. So it's really working with where men are coming from and understanding what their partner's concerns are. Yeah, it is a very, very fast-moving environment that we're in. So that's it from me. Thank you very much for listening.
Thank you so much, Aidan, for sharing your story and the information you provided here. And I think it's about highlighting the human side of of genomics essentially, and what we're doing and why we're doing and why this work matters. So thank you very much for sharing your story and the information. I just wanted to I had a question, and really is that, and I think I have 2 questions actually, is what helped you most in understanding about the genomic testing during when you had the test, taking into consideration all those other elements you've mentioned there about literacy, just thinking about patients in a wider scale. What helped you most understand the genomic testing?
Yeah, I mean, the one thing I've really been fortunate is I've had the same oncologist for 10 years. So that that has enabled me to, you know, build up a relationship, and my wife to build up a relationship that, you know, that is really based on trust and understanding, and yeah, so having a you know, fantastic oncologist has consistently has helped me along the way. Absolutely.
And then my second question really is just, what advice would you give to someone newly diagnosed with prostate cancer?
My advice would be, you know, you're not alone. You know, reach out to support, for support, whether it's to the charities, whether it's to support groups, or, you know, individuals that, you know, that can help you. And don't be, there's no such thing as a stupid question. But you know, it's so important, you know, get engaged, you know, which is hard to begin with, because, you know, that classic stage of denial, anger, you know, kicks in. You know, I've known men who've torn up their paperwork out of anger that had all the information on, and thrown it away. So yeah, so it's, you know, engaging with it, accepting the diagnosis, engaging with it, and, you know, treating it like, you know, men are problem solvers, are information seekers. So get engaged, and find out, because it's important that it's happening to you.
Thank you, Aidan. I don't know if anybody has any question for Aidan. Well, thank you so much for your time and for doing the presentation. Really do appreciate it.
Okay, no problem. Thank you. Thank you for inviting me.
Thank you. Right, so we're going to move on now, and our next speaker is Professor Olaf Ansoj, and I hope I pronounced that correctly. And I can see you on my screen there. So thank you so much for joining, because I know you are joining from abroad. So Professor Ansoj is a consultant neuropathologist, or consultant in neuropathology, the director of the academic unit of neuropathology at the Nuffield Department of Clinical Neurosciences and the University of Oxford. And you are going to talk to us about tissue pathways and a project that you're working on. Thank you so much for joining.
Yes, thank you so much for the introduction. I hope you can hear me and see my slides.
Yes.
Yes, wonderful. So I'm speaking really about a topic that has evolved from being both clinically active, that means my daily practice is involved in rare cancer diagnostics, mostly of the brain and spine, but also informed by my academic interest, which is essentially to ask the question, how can we bring new technologies to human tissue analysis to better understand both normal and abnormal functioning? And I focused on a subgroup of cancer people, people with cancer, where I think the impact of what we can do is very much needed. So this is the early stages of a project. And to explain a bit where I'm coming from, I will talk about, well, how do we define currently cancers, in particular, how do we define them with a rapid progress? And there I want to introduce something that we in neuropathology are using for a few years now, which I like a lot, but is not used very much in other specialties, which is essentially the concept of the integrated or layered histomolecular diagnosis. Then I will briefly talk you through about current standard of care pathology, the dominant pathways and its problems as I see them, then introduce two technologies that could become routine in the next 5-10 years, and then a few suggestions for the way forward. So why focus on rare cancers in CTYAs? So they're individually rare, but collectively common. They are often neuroectodermal or mesenchymal in origin, which both these tissue types are sort of related to my sort of practice. So I feel I can venture into these other cancer types without upsetting other people. So, and one of the observations is that they often fall into siloed pathology specialties. And so the question is not what could be the best tissue pathway, but the question is often, well, is it pediatric, is it soft tissue, or is it brain? Then we send it to that laboratory. And I'm now working with colleagues in pediatric pathology and soft tissue pathology to overcome that. then by definition, they're not only rare, but they're also poorly defined, mostly because not much research has been done. And by poorly defined, I mean relative to common adult cancers. They are diverse due to the complex and common germline interaction that we can find in the young onset cancer people. And they lack precision therapy for most of these types because we don't know much about them. And one prime example is the sarcomas. They basically look all the same on the microscope, and there is no really good treatment. Radiotherapy and chemotherapy often don't work. And then for these people, from my experience, and I will share an example here, that how we currently do testing is iterative, duplicative, wasteful, and therefore slow. And sometimes it exhausts the biopsy, which is tiny, before the crucial test is done, which results, of course, in lack of access to what we call precision oncology. And the other thing that's often forgotten, which is since inception, the mission of the NHS, particularly in these rare cases, you should ensure that research and clinical trials sightline is considered. Anyway, so we, not only in Oxford, in the UK, but internationally, we classify tumors according to WHO standards. These standards are issued every 5 or 6 years, and they increasingly, certainly for nervous system tumors, which are common in young people, include increasing genomic information, including genomic information that defines a diagnosis rather than being supplementary to a histological diagnosis. And that is important. In other specialties, that is less so. Now, in neuropathology, given the rapid progress and the slow progress with issuing the definitive guidelines, which is only every 5 to 6 or 7 years, the neuropathology experts who also inform the WHO classification have created a subgroup where they issue periodic guidance about what new molecular data may be clinically relevant and therefore should be considered in applying best practice. And now to this concept, which I am trying to also convince my colleagues, not in neuropathology, that this is a very good intellectual and conceptual idea to stratify the differential diagnostic information that ultimately makes a specific cancer type diagnosis. And the layer 1 is essentially a synthesis of the other more classical layers, 2 and 3. What do we see under the microscope? How do we grade it according to current protocols? And then layer 4 is a flexible layer where you can put all the molecular data that you, usually the pathologist, deems necessary for tumor typing or choice of therapy. And then you arrive at an integrated diagnosis, which takes these layers into account. And that can be clearly communicated. Our clinicians now also know what it means if an integrated diagnosis, for example, supersedes an original histological diagnosis after taking into account molecular data. So contradictions are going to become more common as knowledge increases. So I'm walking you through now, because the title was Tissue Pathways, using brain tumors as an example, but you can replace brain tumor for any other rare solid cancer in youngsters. So it starts off with the surgeon either doing a needle biopsy or a larger resection biopsy. So we have established, because we are fortunate that we are a 1-minute walk from theaters, and that is an important operational problem, that not all pathology departments are near theater. So we have told the surgeons everything you remove needs to come fresh. And sometimes this is tiny, and we have 3 options essentially. It may all look tedious to you, but I hope it will become clear why I'm telling you this. So what do we do in neuropathology more than in any other specialties? We do what we call a squash preparation. We take a tiny bit of this, squash it between glass slides, briefly fix it, look under the microscope, and then tell the surgeon during the operation what we think it is. Then what is not commonly used in neuropathology or in general pathology is that you actually create frozen sections routinely of the tissue. But what is the most common pathway is that things are disproportionately thrown into formaldehyde, fixed in paraffin, and then paraffin sections are done. Again, all these approaches could lead to a morphological interpretation, And then you can, of course, create derivative materials from this. But first, I want to, and I'll come back to this later, the interoperative old-fashioned squash cytology in experienced hands gives you already a big clue what you're dealing with. So 80% of these quick 10-minute diagnoses are ultimately correct in terms of what is the tumor type. Obviously not what treatment mutations are present, but what's the tumor type. And then you can, based on this information, triage samples either to snap freezing, that meaning a bulk of the tumor is put into a tube and frozen, and you know that what you do is containing tumor. Then in an ideal world, and I'll come back to this, you have a cryo section where you get all the morphological information as well. That's currently not done. And then the common pathway is tissue and paraffin sections, and then you decide which way it can go to molecular analysis. And what you can do in the genomic medicine laboratory hub depends on the source material. So generally, the fresh frozen tissue is currently only used for short read Illumina whole genome sequencing, and then only in those cases where it is indicated in the test directory. And we just heard in the first talk that the indications are being reduced. And then most of the standard of care testing is done on paraffin extracted DNA or RNA using next generation panels, and we are using an epigenomic array and arrive at the integrated diagnosis. Now, what is the barrier to progress? So in my view, and it's the issue of iterative testing, which includes duplication of testing. We heard that there is no funding, so we need to become smarter and what tests to use, and we need to decide at some stage which tests to not use anymore. Then there is the poor DNA RNA quality due to formalin fixation paraffin embedding, which, I mean, yes. So why do we make tissue worse, then make a huge effort to try to make it better, but never quite reach the original state? That sounds to me slightly absurd. This relates to long delays often. So we are currently auditing this. So some rare young cancer people do not get their diagnosis until 2 or 3 months after biopsy, and some people don't get it at all because material is exhausted. And then if you don't have a very good triage setup, people won't have equity to frozen tissue derived testing that they should be able to have access to. So this is an example from a brain tumor. What happens currently in many labs around the country, including in ours, you have an H&E FFPE section, you do some immunohistochemistry, then in some labs, not ours fortunately, people still do in situ hybridization of fish. Then it may go for an NGS panel according to the test director, and then we have, or I have initiated that we have actually access to an epigenomic classifier here in Oxford. And the concept of the epigenomic classifier is also mostly people are aware of this in brain cancer and sarcomas. It is essentially, the concept in simple terms is that we are not reading the single DNA letters. What we are reading is the pattern of alteration, chemical alterations on DNA molecules, which represent two things: the tissue of origin and the changes that have been induced by any cancerous state, including mutations. So the epigenomic classifier answers the question, what is it? And helps make a diagnosis, not to identify treatment targets. So here to just show you a journey, which is a true case from a few months ago. A young person had a mass subcutaneous paraspinal. A biopsy was done in a peripheral hospital. 7 paraffin blocks were created. No frozen tissue was collected. And then the journey of the paraffin block started to general pathology, dermatopathology, soft tissue pathology, pediatric pathology, and ultimately it landed on my desk. That's a picture of from my desk. I counted 42 immunohistochemistry slides. None of them were diagnostic. A FISH test for a break apart probe was done, which showed that there was a breaking apart event, but unfortunately it doesn't tell you what the partner is. Then an RNA fusion panel FFPE was done, which identified the fusion partner, FLI1. And then the dilemma wasn't over because there is a new entity, and I talked about the importance of keeping up to date in these rare tumors. So most classically, this leads to the Ewing sarcoma, which is high-grade malignant tumor diagnosis, and the morphology could be this. And then there's another tumor which has similar fusions or identical fusions, which is a benign tumor where the excision biopsy would have been curative. So the question was, can we help? So I favored it was this, but can we find an objective test that help us to distinguish between the two? This was all contained in 12 pages of report, and the other specialties didn't have access to this epigenomic classifier chip, but I had. So I ran it, and it came down on the Ewing sarcoma diagnosis. So everybody was now happy that we had finally reached a diagnosis after 3 months of a malignant tumor, which is not good. Anyway, so this leads me to the important question that clinicians and pathologists often not aware, but we need to be very much aware of. What is the purpose of molecular diagnostics? And I see it. The purpose is twofold: to help to make the diagnosis when genetic alterations are disease defining, and that is basically a combination always of histology and in our context, epigenomic classifiers. It tells you what it is. And then the other purpose is, of course, can we identify targets for evolving or existing precision therapy? That is done either through the NGS panel sequencing or the paired blood whole genome sequencing. And there are different technologies that are good for these different options. And the technology that I want to speak about now is the Oxford Nanopore Technologies sequencing approaches, which has made quite a wave of interest in neuropathology. And I will introduce the technology in a moment, but what we have learned is that this EPIC array, which is based on paraffin, and the classifiers can be replicated or even improved on if we use the epigenomic data that comes off Oxford Nanopore technology sequencing, which requires frozen sectioning. And these agree to a very high degree. Oxford Nanopore testing is not yet very good at having the resolution that you get with Illumina short read sequencing, and the congruence between those two parts of genomics have not been explored yet. So what is Oxford Nanopore Technologies, in case you don't know? It's a spin-out from the Department of Chemistry in Oxford, and it is a third-generation sequencing technology. The first one was Sanger sequencing. The second one is our NGS Illumina panels and whole genome Illumina sequencing. And there are two main companies, PacBio and Oxford Nanopore. And the distinct advantage of Oxford Nanopore technology is that you do not need a huge building with a 2 million pound piece of kit. These sequencers have come in different sizes, and some of them are portable. So in other words, they could be used for near patient testing. And the other advantage of both PacBio and Oxford Nanopore technologies, they're single molecule testing, and they give you both the sequence as well as the epigenomic modifications in one workflow, and they're fast. So the question is, can we now do real-time molecular diagnostic? In other words, can we reduce it from 3 months or 2 months or 6 weeks to a day or two? So the concept of Oxford Nanopore is really very ingenious. It's an organic nanopore that refers to the size, membrane, inserted into another membrane, and this membrane is under a very low constant current. As the molecular motor threads individual DNA molecules through the pore, the current of the pore is disturbed, and the pattern of disturbance is representing one of the bases, and not only the bases, but even if the base is modified or not. In other words, if there's an epigenomic mark on. And you can see really the outcome in real time. So this is where this has gained major attraction, because the congruence between the EPIC array has been shown for neuropathology. So there is a debate now where I'm trying to influence the direction of travel. So many neuropathology laboratories now saying, oh, we want to do this in-house, because to make an integrated diagnosis for many rare brain cancers, we need histology and epigenomic classifier, and we can get that in 24 hours from frozen sections. To which I say, yeah, that is all very well, but you are not going to fragment services that were just integrated, and I think makes sense to integrate them, again, by becoming a local genomics expert. And neuropathologists are not trained to do that, let alone set up for quality control. So there's currently a debate which could be done locally and what happens to the data and the curation and further deeper analysis on the same material. And I strongly believe that this can only fly also with the NHS funding and the strategy if we integrate it with genomic medicine laboratory hubs. But I'm the minority here. So what's the current strength? You can use it for rapid integrated histological diagnostics. And in the future, it will also be as good as Illumina sequencing with target discovery. And there are major challenges to do this. No department has established this in the NHS and it's not accredited. So what does that all mean for pathology? So I think it is pretty obvious. You need to make the tissue fit the technology and not the other way around. And I don't know if there are any pathologists here, but I'm considered now, unfortunately, being a heretic for the reason that I say formalin and paraffin tissue had a good run of 100 years. Yeah, you need to think very hard when it is justified to throw a lot of your samples into formaldehyde. And then I get this response. But you cannot be serious, quoting McEnroe on Center Court, to replace FFP pathology with cryosection pathology. To which I say, can you read this sentence? I'm sure you can. You do not need to see everything to make a diagnosis. And now we are coming really into the cognitive aspects of all what we are doing. People get always bogged down on individual tests. Essentially, contextual inference is part of any diagnostic process. We may not be aware of it. It's called knowledge and experience. Now we are in the digital histology world, and it has been shown that computer-assisted image analysis is better to extrapolate from the unusual features you may see in cryosections to what pathologists are used to. So they can create from cryosections a virtual paraffin section, if that's the problem. Therefore, cryosections are good enough in the digital age. It also, if one moves to cryosection, it also has one other target, because apparently there's a strategy to arrive at a formalin-free hospital. Wasn't aware of that. And then from a scientific view, cryosections are the only way to get close to unbiased in vivo histomolecular spatially resolved features, apart from doing live slice analysis. So to illustrate this here a bit more in rare cancers and really in any diagnosis, you do not operate in a void. Yeah. So you have the radiology, you know what the surgeon's up to, and the challenge of molecular pathology, or particular histopathology, is not stating the obvious. Yeah, you know already 3 differential diagnoses before the surgeon has even started. So essentially, we need to triage tissue to maximize context-dependent insight. And we heard this before: right test, right patient, right time. So if I were to set up a new precision molecular laboratory based on tissue, now I would focus on 2 technologies. I explained ONT, and there's another technology which is mass spectroscopy, or mass spectrometry, because we are all very interested in the genome and its dominating, particularly if we can do it, but you lose most of the downstream, well, all of the downstream information about proteins, metabolites, particularly if you have drug trials, do they actually reach the target, etc., etc. All this can be derived from the frozen section with mass spectrometry. So instead of you looking for one molecule at the time, you can look at everything and filter accordingly. So if we really want to move to the next step of precision oncology, both diagnostics and research, I would say all you need is this. How can we achieve that? And that's what I'm trying to do in my role as a CGIP partner. We need to work together more closely. And how we move forward. So that's now my project here. We're currently doing audit of the standard of care pathway with the aim of running a head-to-head comparison between a new Oxford nanopore technology-driven pathway and cryosection pathway which we heard this before in the first talk, which will include some cyst fluid and plasma for the liquid diagnostics. And the biggest value is if you at the same time have both tissue and liquid DNA to validate what you find. And we have to start small. So the task until the 31st of December is to complete the audit with our colleagues. We are including here patient experience. So I'm having the first student who are doing this on adult rare cancers. We're expanding it to pediatric rare cancers. For example, how did they experience the odyssey of getting a diagnosis? How have these often very complex diagnostic categories been explained to them? Have they been asked about research? The last bit, I already know the answer, no. So we're doing 150 cases. Then there's great interest to expand it to our region, so essentially Birmingham, Southampton. Then I would like to have an outreach day, and I would be very keen if I get input from the audience here, early 26. And then the crux of the matter is I need to get some cash, but there are some charities who are very keen. And then if you really want to make a difference, you need a big grant from UKRI. Thank you.
Thank you very much, Professor, for that really fascinating presentation.
And I'm sorry I talked for longer than intended.
No, we're not too much over. But I think my question, well, not even a question, I think the comment is that it's going to be quite exciting to see that if this advancement in pathology and genomics will help to speed up diagnosis and improve the outcomes for people with young cancer. So I think that's my comment that I have to make. There is a question in the chat from Belinda, who's asked, has digital pathology not allowed this process to speed up rather than slides being sent around the country?
Yes, so I was referring to digital pathology as a tool to bridge also the critical objection that I hear from pathology colleagues saying we are not used to looking at cryosections. At the moment, no cryosections are scanned, although it's easy, we are scanning the paraffin sections. They're not even created. And what is being sent around the, yeah, you're referring to the index case, yes, where all the blocks and the slides were sent. I don't know why they all ended up in Oxford, to be fair. But we have now, for the histology, a mechanism, certainly in our region, Pathology South 4, which matches on GMC Central and South, a way that we are allowed with NHS colleagues to share digital images. However, sharing the digital images does not allow you then to do tests for which you need the physical material. So historically, but it's a very important point, historically, the amount of shipping of stuff that goes on in the NHS is mind-boggling. Yeah, and it's a monumental waste of human and, courier resources.
Yeah, I think that's a challenge that we are all working through at the moment. So if you want people to join, or if anybody's interested, do they contact you directly?
Yes,
Okay.
It's at the moment a one-man show.
Lovely. Thank you so much. Thank you so much for joining us from abroad as well. And if anybody's interested, please do get in contact with Professor Olaf Ansoj, or otherwise you can contact me and I can forward everything on to yourself, Professor.
Thank you so much.
Thank you. So I'm just going to reshare my screen. There we go. So we're moving on now to our final speaker, who is Dr. Kate Glover, who is the Quality Improvement Lead and Clinical Scientist at the Central and South Genomics Medicine Service. And Dr. Glover is going to talk about some improvement work that is going on, service improvements, and how we can hopefully be reducing some turnaround times and improving some processes. So, Kate, are you there?
I am. I'm here.
Fantastic.
Thank you.
Just let me know when to move slides on.
Yeah, I just crack on. Thank you. And thank you for having me today. It's lovely to be able to have the opportunity to share briefly some of the work that's going on in this space. So thank you for the lovely introduction. I don't need to dwell on that. So if I can have my next slide, I'll tell you a bit more about what CGIP is. Lots of acronyms in this space, but hopefully it will be clear enough. And if you do have any questions, please drop them in the chat. So what is CGIP? Olaf already mentioned briefly that the piece of work that he is doing feeds really nicely into what CGIP is, and it is the Cancer Genomics Improvement Programme. And this is a nationally funded programme. There are 7 genomic medicine services across the whole of England, and each region has one of me, or the equivalent to me, in a quality improvement lead position. So I'm a clinical scientist by background. My background is actually rare disease, but I have a specialist interest in improvement techniques and applying those. And over the last year or so, we've really started to make improvements in the cancer space. So I'm still learning, and there is huge amounts to learn, but this programme is, we know, something that will appear in the new service spec for genomic medicine into sort of the next few years, and it's really amazing what you can do, and I want to show you a couple of examples of that without spending a lot of money, really. So just back to this particular slide, we when I say we, I mean myself and my very able and brilliant project manager, Kat Omar, who's also on the call. Between us, we meet with the genomics unit once a month, and that's driven from NHS England. We have to submit a highlight report, which has got a series of agreed actions on it, and this is a regional project that covers the whole of our Central and South region. And anything and everything is not off the table, but I will show you, if we can move to the next slide, Phil, what sort of I guess that the idea is. This is a really busy slide, and I'm not expecting you to look at the detail particularly, except to say that this is produced by NHS England, and it shows you the sort of the complexity associated with solid tumours in this space. We talked a little bit, Olaf's already talked about pathology services, and what this essentially this whole programme hinges on, from the point at which a sample is taken from a patient, acquired either by biopsy or resection, and at the point that sort of that's the clock start, if you like, and then that flows through cellular pathology, which is the sort of second middle strip of this particular diagram there in the lighter green. And then just at the bottom of the slide, you can see another little blue box with CPGC in there, and those are cellular pathology genomic centres, and those are a relatively new sort of bridge, if you like, between cellular pathology and genomic services. And then the sample flows to the GLH, the Genomic Laboratory Hub, for testing. And that whole process is hugely complicated. You can see by the little van diagrams on there, we were talking about moving samples around. That denotes every time a sample has to move around, and actually what's not represented here is the fact that none of the limbs are integrated, so there's lots and lots of repetition, duplication of effort in this space. And so CGIP was stood up to see what could be done in this entire end-to-end pathway to improve and reduce, more importantly, turnaround times for cancer patients across our region, but also across the country. So if I could have the next slide, please, Phil. So just to say that there is a huge amount of stakeholder engagement in this space. This is not an exhaustive list by any means, but these are the groups of people, I guess, that we have engaged with. So that's laboratory colleagues, both within the pathology space and in the genomics world. But we've been working extensively with cancer alliances across the region, with clinical teams, and also not forgetting our sort of colleagues in the clinical trial space, and how the importance of getting a timely genomic result feeds directly to those trial, the sort of trial opportunities for patients. And we are also really fortunate to have a fabulous PPI rep within our region who keeps us very much sighted on the patient perspective, and we never lose sight of that in all of this work. So if I could have my next slide, please, Phil. So quality improvement has been around for many, many years, but I think it's relatively new in this space. And I just thought it was helpful here really just to kind of highlight some of the approaches that we've taken when viewing some of these processes that go on. So I like to think of quality improvement more about quality or process improvement rather than strictly quality. And I think the definitions vary according to which space you are in. But essentially what we're doing is the idea of introducing a change if a change is appropriate to do so, but also making sure that that change is sustainable and it's not something that a lot of effort goes into that then very quickly it falls by the wayside. So that underpins everything that we are doing. Lots of information gathering, do huge amounts of observation of different processes. It's amazing what people kind of introduce into standard protocols and didn't know that they were doing that. And I think there's a lot of asking why, and why are we doing that? What's the value? Where's the waste in the process? We've been really fortunate to visit a number of different sites around the region, which has been really helpful. Everybody has been really, really keen to have us on board. And if there are any other people that are in this seminar today that feel that they would benefit from a visit, then please do sing out. There's a really big element to this that involves data. Everything that we do, I'm a clinical scientist, and Kat, her background is data, and we like to underpin any changes that we recommend to be sort of rooted in that data approach for evidence, really, of the fact that that process has worked. So if I could have my next slide, please, Phil. Okay, I just want to give you an example now of something that is quite specific, but I think it's a really valuable way to sort of highlight a particular project, of which there have been many over the last year. So hemato-oncology is the sort of the patients with a liquid, we'll call it a liquid cancer, and they're rare and also challenging, I guess, in some cases to access genomic markers which inform treatment. We've heard about that today already, and it's exactly the same in the hem-onc space. So this particular work hinges on an NGS-based panel service, which was developed and designed, I guess, when the routine turnaround time for these patients was set at 21 days. The turnaround times are set by NHS England in collaboration with professional groups. And when this particular service was developed, it was set at 21 days. What happened subsequently was that turnaround time was reduced for some of those patients down to 14 days. And that posed problems for the teams in the laboratory because their wet lab process, so the actual act of performing the testing, was set up to be delivered to allow for that 21-day turnaround time. So we're a collaborative group. The laboratory testing takes place across the region, and some of the testing is consolidated to make maximum efficiency savings, I guess. And our colleagues in Wessex send samples up to the laboratory in Birmingham, and that part of the service is consolidated to testing there, and they send their samples for this wet lab testing, and then the information goes back using a cloud-based distributed analysis model for the team down there to analyze their patients. So because of that additional moving of samples around, which is necessary to sort of the health economics piece, means that we really do need to maximize the number of patients going through this process. That adds another delay into the system. So it wasn't really possible using the current protocol to get to that 14 days. And just for a bit of perspective, this affects around about 90 patients a week, which is the combined the numbers across the Birmingham and Wessex laboratories. So I could have the next slide. This is a slide that was supplied by Wessex colleagues, just to highlight that actually they send these samples up once a week. The reason I'm showing you is that quality improvement and process improvement is very much multifaceted and really quite complicated. And any improvements that we made need to be mindful of the day of the week, I guess, that these samples are received and prepared and then sent on. And so I just think that this illustrates quite nicely that the vast bulk of the sample, 76%, are actually received into the Wessex laboratory from patients in that region at the middle of the week. So anything we needed to try to maximise capturing as many of those as possible. So next slide, please, Phil. So the quality improvement work involved an extensive options appraisal. Essentially, we looked to reorganise the schedule that was that was the best route that the team in Birmingham that were delivering the wet work were able to come up with, and we developed a new run schedule, which sounds very simplistic, but actually wasn't. In a busy laboratory, it's really difficult to tweak some of these things, and there are also many other contributing factors and other workloads that feed into this laboratory space. But a success story nonetheless, and it actually resulted in, once this new schedule was implemented, it actually resulted in a reduction of 4 days in the wet lab pathway, which took it from 13 days. So you can see there that the wet lab piece was almost occupying all of that first 14-day turnaround time, down to 9. And the key thing here is that there wasn't any additional money spent other than just the resources required to review the pathway. And actually the benefit of this not only means that that data is available earlier, but actually it releases resources in terms of staff time to be able to redirect to other areas, and that the results then effectively are available more quickly for review. So I think the next slide gives you a real life example of how this has already benefited a particular patient. So this patient was a neonate suspected TAM, which is transient abnormal myelopoiesis, which is very commonly associated with Down syndrome. And often patients are not necessarily diagnosed with the Down syndrome before the TAM. So TAM is initiated when there are somatic GATA1 mutations that occur early on in fetal hematopoietic development. And if you do want to know some more, there's a really nice review article there. So this patient was critically ill. The clinician phoned and said, we really do need to make some decisions. Are there any genomic results available? And the team in Birmingham, in this case, were able to access that data, which had come off earlier than expected. And so this case could be prioritised. And the result did confirm that patient had a GATA1 variant, which is clinically actionable. So a really nice example of how just by tweaking that scheduling, it was possible to get that result available for the patient earlier. And the total turnaround time for this case was 11 days, which is really quite exciting. So I think I've only got another couple of slides. I'm conscious of time. I just want to show you something else that is really new, really hot off the press, I guess. The last time we met with the genomics unit, each region was given a tumour type. Ours is endometrial. It's difficult to find in amongst that big table there, but we've been given endometrial as a tumour type to do a regional deep dive. And so Kat and I are now in the process of engaging across our networks to understand more about what the challenges are in that particular pathway. The idea behind this piece of work is that you can learn from each other, and we're already seeing that actually good practice and some of the sort of the common themes that are coming out when the QI leads and the QI team meet nationally is already proving to be really very useful. And we're hoping that by doing these deep dives, we'll be able to share even more sort of valuable information which can be applied across the country. So if I can have the next slide, please, Phil. This just gives you a snapshot of where endometrial cancer appears in the National Genomic Test Directory. We've heard already today about Lynch syndrome testing, but this is there are two arms to this essentially. So a patient may present with endometrial cancer, but then it's how that aligns to the germline Lynch testing and also the prognostic markers, which are important when treating a patient with endometrial cancer. And I don't intend to dwell on that, so I know we've already talked about that today, but just to let you know that this is really starting to kick off now. And if anybody's got an interest or anything they feel that they can help with, or any comments, questions, then please do let us know. I think that's me done now, Phil. It is. Excellent. Thank you.
Thank you very much for that presentation. And I think it's just clear to show, you're just showing that collaboration and quality improvements are really helping to deliver those faster results for patients, which is really important. I can't see any questions in the chat. I don't know if anybody has any questions to ask. But as Kate said, if you have any, or if you want to, Belinda, do you want to talk?
Yeah, well, just very quickly, just a quick question. I know it's the Southwest and it looked at the prostate. I was just thinking there is an NHSE prostate dashboard, and I know the Southwest have got a prostate dashboard, but genomics isn't part of that at all. Do you think at this stage we should be pushing to try and get, you know, something like BRCA or whatever actually part of that dashboard, rather than waiting for several years of iterations of that dashboard to come through?
Dashboards and data are an ongoing conversation in this space, so I think very valid point, and certainly something which the quality improvement team across the country are looking very much at that. The challenge, I guess, in all areas is how that data is captured and presented back. So the data that's submitted from the genomics laboratory is in the form of PLCM, patient-led contract monitoring, which is slightly different, and it is a bit more complicated, but absolutely agree with you but there is a real lens on data and dashboards, so I'm hopeful that it won't be too long before those metrics are combined into one visible space for clinicians to view.
Thank you so much, Kate. There's no other questions, but thank you very much for that presentation. I think overall, what this webinar is just showing is that there's so much work that's been done behind the scenes and mainstreaming and everything, and with the hope that all this will be an improved outcome for patients, which is the ultimate aim, but ensuring that we have got the right test for the right patient at the right time. So thank you very much, Kate. So just to quickly, and I know we've come to the end, so I just wanted to quickly just highlight some educational resources that are available. If you wanted to learn more about genomic and healthcare, there is our newsletter that you can sign up to, so you can just scan the QR code to subscribe and you'll receive updates on all the educational resources that we have, if there's any research and much more information as well that comes from that newsletter. So please do sign up to that if you are interested. And then it's been mentioned before, but there is the Genomics Education Program that provides those online courses, bite-sized learning. It offers some free learning as well. With some MSc modules, and then there's GE Notes, which has got the clinic platform. So if you are a patient and you wanted to find out what to do with that patient at that point, you can go to the in the clinic link, or otherwise, if you just wanted to find out more and get increase your understanding and knowledge, there is the Knowledge Hub. You can also find resources on the e-learning for healthcare platform, as well as on the Macmillan Cancer support page. For nurses as well, we've developed a nursing genomics learning passport that is available to download, so you can increase your genomics knowledge step by step in your own time. It can be used towards your revalidation, and we are currently just finalizing our Genomics in Cancer learning passport for nurses that we'll be piloting, hopefully be sending that out by the end of this week, beginning of next week, to our nursing colleagues. And just to say, you don't have to be a nurse to use the passport if you just wanted to increase your specific genomics knowledge, but the passport will be available, we hope, on the Genomics Education Program website. And so thank you everybody for joining. We do have a short post session survey for you to complete. It's really important for us just to find out whether this has been interesting, whether you would like more of these. So please do complete that. And if you have any questions, or you wanted to get in contact with anybody, you can come through via our website, or you can contact me directly. But thank you everyone for joining.